Welcome to our podcast, Psychiatric Services, From Pages to Practice. In this podcast, we highlight new research or columns published this month in the journal Psychiatric Services. I'm Lisa Dixon, editor of Psychiatric Services, and I'm here with podcast editor and my co-host, Josh Berezin. Hi, Josh.
Hi, Lisa.
Today we're going to be interviewing Dr. Patricia Deegan based on her new personal accounts column.
Yeah, and for those of you who, I think a lot of you may be familiar with Pat Deegan's work, but for those of you who aren't, this column is a really great, almost an introduction, but also a summary of a lot of her ideas. And not only is it interesting, but it's also inspiring in a lot of ways. So we hope you'll enjoy it. So we are incredibly lucky to have Dr. Pat Deegan with us today on the podcast, and she's one of the principals with Pat Deegan and Associates. So maybe before we get started, Pat, you can just let us know a little bit about what Pat Deegan Associates is and what kind of work you do for those listeners who aren't familiar.
Sure. So again, my name is Pat Deegan, and I run a small company that's run by and for people with the lived experience of their own recovery after a diagnosis of serious mental illness. We're a group of about 8 people, and what we do is to develop tools and technologies that support people in having a voice and a choice, and also being able to say how treatment will help me. And our tools and technologies really focus on helping people have a voice and a choice in their care and in finding the treatment that's right for them. We also develop tools and technologies that support providers in offering recovery-oriented services as well.
So we're going to talk about the column you have and this is part of the personal accounts column, which you also are the co-editor of, correct?
Right. Pat just assumed the editorship with Will Torrey.
So we can add that to your long list of illustrious of titles. So, usually when we do interviews, we start out by asking people how they got interested in their particular area of research or what their particular column or paper is about. But for you, I was kind of more wondering how you got to the point of incorporating your own experiences in both your research and your advocacy work.
Yeah, sure. So, when I was 17 years old, I was first diagnosed with schizophrenia. I experienced my first episode of psychosis, went into a psychiatric hospital and went on medications for the first time and was seen via ambulatory care while still living at my parents' home. And, in that process, I decided that I really had a vocation. I felt called to carry the good news that it is possible to recover after a diagnosis of serious mental illness. I had been told I could never be well. I was told to avoid stress at all costs and to take medications. And that turned out to be a really inaccurate description of what I needed to do in order to get a life. I was interested in getting a life. And so for me, learning that there were things that I could actually do that would help me manage distressing voices, or things I could actually do that would help me manage false beliefs. These were incredible revelations. And I found that my psychiatrist and my therapist and other members of my care team and I had to develop a very, very different kind of relationship in order to get a life that I wanted to live. And so once I had found kind of my way through this, I decided I wanted to become Dr. Deegan. I wanted to go on and get a doctorate in clinical psychology to carry the good news that recovery is real. And really, that's what I've devoted my 30-plus year career to doing, is exactly that. To pretty much anyone who will listen, I have a message that recovery is real, not for a few exceptional people, but for everyone, that it is possible to get a life of high meaning and purpose.
In this particular column, which you've titled "The Journey to Use Medication Optimally to Support Recovery," you're conceptualizing these 8 kind of challenges in using medications. But before we dive into some of those challenges, could you just talk a little bit about the idea of recovery as a journey? It's the first line that you have in the column, and I think it's just like such a helpful framework for people. So how did you come to that idea, or how do you think about recovery as a journey?
Well, I think recovery is a journey because I think it is a journey. It's not something that happens overnight. It's not like being restored or cured by an outside force or technology or medical breakthrough. It's more like living each and every day and trying to find a way to do the things that matter to me, even when struggling with symptoms and other forms of distress that are associated with diagnoses. And so for me, it's a process of learning. It's a process of growing. It intermeshes with the process of aging and typical development. And it involves much, much more than just sort of a psychological or psychiatric worldview. It involves my spirituality and the evolution of my spirituality. It involves my work. It involves my relationships. And all of these things unfold over time in a way that's really important to conceptualize, that we do not, at the point of diagnosis, lose our resilience. We, in fact, continue to cope for answers, and that this is a journey. It's a long trajectory. It's a learning experience. It's very different than the concept of cure. And as I like to say, I like to keep it really simple. And recovery for me, in the end, means having a paycheck, a job, and a date on a Friday night. It's that uncomplicated. It's wanting to live the life that in many respects is similar to what other citizens and how others want to live their life. It's about making the transition from focusing all the time on what's the matter with me and getting to what matters to me. That's the journey, right? And it takes a different kind of relationship with our care providers than I think is widely understood. I think sometimes people fail to understand that that's part of the dimension. We have to work with people differently to help ourselves as clinicians get the focus off of what's the matter with you and onto how do we get to what matters to you, because treatment then becomes the means to getting to what matters to you.
It's such a powerful message, and the metaphor is also so helpful in thinking for me as a provider and thinking about how I'm just interacting with people and what kind of decisions I'm making. So when I read the paper, I thought of this like journey. Recovery is a journey, and there's certain challenges that are going to come up. And I thought about it a little bit like kind of like a guidebook. The paper, the column is kind of like this guidebook to going on sort of a long hike in the backcountry. Like you might not encounter all the issues that come up, but it'd be really helpful to know before you go out on your 10-day hike or your year-long hike or however long you're hiking for. You want to have a map. You want to have a flashlight. You want to know what poison ivy looks like. You want to know what to do about blisters, what happens when you get a twisted ankle. And then also you want to make sure that there's a little reminder in there that the point of this is to, have fun and enjoy the scenery and the sunsets as well. So it's simple and it's powerful. I really like this idea that you're playing around with in the column.
Thank you. Yeah. I think that your analogy of the idea of a long hike and gathering information ahead of the hike so as to be able to manage whatever is encountered as far as we can. And there are certainly many things we can't anticipate. But then again, that's part of our resilience too. We usually will find a way because we got to get to the other end of that hike, right? Yeah.
So as we always do, we encourage people to read the column, but particularly for this one, I think it's 2 pages and it has the potential, if you're not familiar with Pat Deegan's work, particularly it has the potential to really shift your paradigm about how you're thinking about working with individuals. So you've laid out this idea that recovery is a journey, and there's these 8 challenges that you lay out. And you also, in the column, you flag some things that, some comments or some ideas that might come up to tell you when that sort of challenge is coming up. So I was wondering if you could just, I don't think you need to walk through all 8 of the challenges you lay out, but what are sort of 1 or 2 that you could share with our listeners here, and what the challenges are, and sort of what that warning signal is that's coming up?
Sure. Well, I think one of the biggest contributions in this particular paper is the notion that one of the challenges in using medications optimally to support one's own recovery involves redefining the sense of self. It means realigning how I understand myself, my story of self, with the fact that I am now using medicines. And this is a very important challenge. Some people might say things like, well, I didn't think that I was a person who needed a crutch, right? Well, part of coming to terms with using medicine and that new sense of self is that, is this a crutch for me? Or what is this for me? And does this mean that I'm weak? Does this mean I should just pray more and go to church more and that I somehow have failed? And so it really challenges that sense of self. But I think another key area, in my experience in treatment and psychiatric care, there was always this sort of reigning assumption that there's the me before I take medicine, and then there is the me that is using, for instance, in my case, an antipsychotic medication, and then somehow that antipsychotic medication returns me to that older sense of me. And I would really disagree with that and say that what actually happens, I think, for many of us is that when I use an antipsychotic medication, it sets up a third sense of self. That sense of self is me on medicine. And so the changes are important. So, for instance, I might find myself with a more sedentary and lacking energy, and perhaps even gaining weight. This may be a whole new sense of self for me compared to myself before using medications. And I think that when we can understand that as clinicians, it truly begins to deepen our understanding of the human being that we're sitting with and just how tough that would be to align a sense of self, the story of self, with this newly emerged self, which is the me on medicine. It's a whole other thing to come to terms with that self. And of course, there are also really good aspects of that me on medicine sense of self for some of us. And that might be that I'm getting along better with people that matter to me in my life, or I'm able to do my job more successfully. Those things matter too. Those are the easier parts. The harder parts are the unwanted experiences when I'm using medicine. For instance, even something as simple as the bad breath that sometimes goes with using an antipsychotic. And that's a very hard thing to disguise, no matter how you try, right? And so people begin to sense, oh, maybe something is different about her, or that saliva that congeals in the corner of your mouth sometimes. So this is an important contribution I think this paper makes.
Well, I think in all of that, it is such a driver of empathy in a conversation that can seem very distant and cold when not done in the way that you're kind of talking about, to talk about, this is the list of side effects you may experience, and you need to come in and get your blood tested on these days. There's a distance in that interaction. And in addition to creating, it's an invitation to empathize with somebody's experience, it also is an invitation to make the work a lot more interesting for the clinician, that you're not just managing side effects. You're like, the idea of that this has something to do with somebody's identity and sense of self is such a more interesting interaction to have with somebody. And it kind of brings out, I think, some humanity on both sides of the conversation.
Yes, I agree. And so I call my work the Common Ground Program, because it's my belief that finding the common ground of our shared humanity is the basis of all recovery-oriented practice. And the common ground is, maybe I as a clinician have never used an antipsychotic before, so I can't relate. But I do know what it means to have bad breath and to have somebody, maybe take a step back, right? And so it just becomes, like you say, an avenue to create the common ground, create the empathy. I really think that Oliver Sacks said it best when he reminded us that the best clinical work occurs when we can deepen a clinical case study into a human story. And getting to the human story is really what makes for a brilliant clinician.
Yeah, I just love listening to how you think, Pat. I also wanted to make the point, something that Josh underlined, is at the end of each section or each challenge, you give a kind of a quote or a way for the clinician to glean that this is the challenge with which the individual they're serving is coping. And so at the end of the paragraph, when you discuss this challenge, you say people experiencing the challenge of redefining the self might say, quote, "I don't feel like myself anymore." And that gives us a kind of maybe that's, maybe this is the challenge that the individual is kind of thinking about. I like those quotes.
This is what's so helpful about this particular, 8-challenge framework, is the idea that if a clinician is listening for the challenge of a person struggling with redefining self, if they listen, they will hear things like, "I don't feel like myself anymore," or "Am I weak because I take this medication," right? And so I think that these are like little red flags that can go up for clinicians and say, okay, we're facing a challenge here. And my task then becomes as clinician to get off of the compliance, non-compliance approach and to be thinking in terms of how do I support this individual through a challenge, which will mobilize an entire clinical team in an entirely different way, given the tools to support that person through the challenge.
Yeah, I think about looking at the ground and somebody's like, look at all the ants, and you don't see any ants, and then you find one, and then all of a sudden you see all these ants all over the place. So like it's a way to tune in to having these prompts that you have in there is a way to kind of put people's antennas up to things that might come up, and you can sort of say, oh yeah. And then at the end of the article or the column, you have this really this analogy that I really like about being a little league coach or being a student in a culinary school. So maybe we can end with that. What did you mean by those? What were you trying to evoke with those analogies?
Well, I think what I was saying was that in the end, optimal use of medication to support one's journey of recovery is when we hit that sweet spot. And it is a sweet spot because it's a journey to get there. But when you finally get there, the use of medications on a day in and day out or every 3-week shot basis fades into the background of my life. And what takes center stage on most days, not all days, but most days, is the fact that I am doing what matters to me, those precious things in life that matter most to us. And so, for instance, being at a child's Little League game or just being a student at school, making custard and getting advice from a chef, that's what it's about. And that is ultimately why you even bother taking the med the next day.
So, Pat, I want you to talk about every single challenge, but I know we don't have the time for that. But is there another one that you would love to focus on in this podcast?
Sure, Lisa. I think that most everybody struggles and feels challenged by the task of finding and discovering and redefining and rediscovering my personal motivation for using medicine. As I said in the article, my parents may want me to take it, my wife may want me to take it, but I don't know why I'm taking it. And I don't feel motivated because the bottom line here is it's really hard to take a medication, particularly when it has associated risks. Sure, some benefits, but also some risks and unwanted effects. It's really hard to do it every day. And so I think sometimes we just assume that having a decrease in measurable positive symptoms would in and of itself provide personal motivation. But I'm afraid that that's not always the case. I think these personal motivations also are deeply tied to what matters to me in my life. Not what's the matter with me, what matters to me. And so I think that helping people in a very proactive way decide, well, how will you know if this medicine is helping, and how will you be able to take that and make that into your personal motivation? So one of the techniques when we hear that someone is experiencing the challenge of rediscovering their personal motivation to take medicine, we might just hear someone saying, my dad gives me the medicine, and he'll take away the car if I don't take the medicine. Well, there you have an example of a red flag. Oh, this person is using it because they want to drive the car, and mostly on dad's initiative, I could proactively as a provider get in there with this individual and help them in an active process of discovering their own unique reason for using medicine. And so really the technique I think that works best in this kind of scenario is asking people what, if anything, are symptoms and distress interfering with, right? So maybe the distress I'm experiencing has meant that I'm too paranoid, too scared, too frightened to play soccer anymore. And I used to love to play soccer. I played in high school and blah, blah, blah. Oh, okay. So then we can think of that as what you might call an inquiry into a dream that mattered to you that you're no longer able to engage in. Then we can think, okay, wouldn't it be great if I could play soccer again? Okay, we've defined here something that matters to you. And then something very concrete that I used over and over again in my own journey was taking an image of someone playing soccer. In my case, at one time, it was an image of my partner, Deborah, and my daughter, Cheyenne, and taping the image, the little picture, to my pill bottle. And I really didn't want to take medicine. I didn't like it. But I would say to myself, this one's for Cheyenne because it's more important for me to be here parenting her than for me to be at the state hospital, right? Or to whatever, And so it can be that concrete, just reminding myself, working my personal motivation, and it works.
The example you use about the father taking away the car, I think after reading your work, the next question that I would ask is, well, where are you going in the car? Like, what is the point of this? Like, why do you want to use the car? Like, are you going to soccer practice? Are you going to the movies? Are you going to see your partner? Like, and then you're in a much more rich and interesting conversation than you are with, let's get a pill counter for you.
So for me, there's an important backdrop from which this, or context from which this article and point of view emerged. And that is what I consider to be the failure of the binary construct of compliance and from non-compliance. That the compliance, non-compliance paradigm really fails us on a number of levels. It's an oversimplification of the challenges to this journey that I'm describing. I think it obscures very important details, and also compliance and non-compliance really dull curiosity. For me, the impact of this article is to offer a different vision of the human being who is trying to make their way through the challenge of their own recovery and using medicine as part of that journey. And that this article, I think, deepens the work to touch that human experience. And that is the common ground where we meet people to support them on their journey.
So maybe that's a good place to stop. But, I wanted to thank you for coming onto the podcast, but also just personally, your work has been a huge inspiration and has made my work a lot richer. And I think the patients who I work with are all the better for it. So I want to thank you for joining us here. And then also just for all the work that you do and the clarity and passion that you bring to your work.
Yeah, I want to echo that. And I encourage people to click on this article. It's open access. Everybody can get to it. You don't need to be a part of an academic institution. And it's clearly, simply written. I personally think every single medical student and psychiatric and every trainee in mental health should read this, as well as, of course, every clinician. And I'm going to work very hard to make that happen. So thank you, Pat. That's it for today. We invite you to visit our website, ps.psychiatryonline.org, To read the column we discussed in this episode, as well as other great research, we also welcome your feedback. Please email us at psjournal@psych.org. You can also rate and review the podcast on iTunes, Stitcher, or wherever you listen to it. I'm Lisa Dixon.
I'm Josh Berezin.
Thanks for listening. We'll talk to you next time.